So good afternoon, all of you. After a couple of outstanding lectures by two giants in medicine, here I welcome all of you to the Young Physician Forum. So today I'm going to discuss about Haemophagocytic Lymphohistiocytosis. Sometimes you might have heard about this, sometimes you might not. And this is a very rare entity, but it has a very high case fatality. That's what I picked up this topic as my today's lecture. So we'll start with the case.
We are sharing something else. We are sharing something else. Okay, move in. Slide. We have open 2 minutes. So we are running on something else. We make it open. This is the one that you want. No, yes. Yes.
So we'll go back to the case. This patient is a 17-year-old boy, previously healthy patient, and he was admitted to a peripheral hospital following acute febrile illness. And he had arthralgia, myalgia, headache, and a dry cough. At the peripheral hospital, patient was managed as dengue fever, and later on, it was said in the transfer form, this patient has been complicated with a DHF, but patient had quite unremitting fever and abdominal pain with persistent thrombocytopenia and the elevated transaminases, which is not settling even after the completion of DHF phase. So for the evaluation, patient was referred to CNTH. So we got the patient and then we evaluated with a happy outcome. Right. In history, patient did not have any rashes apart from this acute febrile illness, no features of any connective tissue disease or a malignancy. Upon examination, this patient was averagely built one, and he had very high spiking fevers. Respiratory system examination revealed a pleural effusion, right-sided, and there was a mild, tender hepatomegaly, and the other hemodynamic parameters were very, very stable. So this was the fever chart. I have shown the fever chart at the local hospital, and the fever chart we maintain at our ward. Both are showing very high spiking and distressing fevers. So these are the basic investigations that we started from. You might see in the full blood count, patients' platelets are quite low. Patients' other parameters like WBC and the hemoglobins were quite normal, but the platelets were a little bit showing some sluggishness to improve. Apart from that, there was transaminitis, which is very severe. Initially, it started from hundreds and it went up to thousands at our hospital. Apart from that, patient had some inflammation also going on. CRP was high. The maximum CRP value we got was 211. And the other basic investigations, including the renal functions, were normal. We did an ultrasound scan abdomen. We had one ultrasound scan abdomen at the peripheral hospital also in our hand. To compare, we did another one, 5 days interval time. And we showed the patient had hepatosplenomegaly with increased liver echogenicity. There was no any intra-abdominal lymphadenopathy. But in the first scan, both hepatosplenomegaly was there with a spleen size of 11 centimeters. In the subsequent scan, the spleen was quite enlarging up to 13.3 centimeters. We sent a blood picture. It was suggestive of a severe viral infection with extreme bone marrow stress, and there was no any marker. So at the end of the history and the examination and the different basic investigations we had, we came to two differential diagnoses. One thing is this could be expanded dengue syndrome with the secondary bacterial infection or with the fever and quite poor resolving cytopenia and the splenomegaly, we thought of possibility of HLH following either infection or a hematological malignancy. So as today's topic, we'll a little bit discuss about HLH and then we'll go back to the scenario later. Haemophagocytic lymphohistiocytosis or HLH is quite aggressive and a life-threatening syndrome of excessive immune activation, and there will be a very aggressive cytokine storm which lead to multi-organ dysfunction. This is primarily considered a disease in pediatrics, and most of the evidences are coming from the pediatric literature, but it can affect adults of all ages. Basically, there are two forms, primary and the secondary form. The primary form is considered to be having some genetic potential, and the secondary form is most of the time acquired. This primary form is commonly seen in patients who are infants and the children, and the secondary or the acquired form is the commonest type within the adult population. And this can be precipitated by various triggering factors. And the physician has a very, very big role here because most of this HLH has clinical severity and a complexity and a rarity. That's why, as we are the first medical people, we need to have a high index of suspicion. Otherwise, the case fatality rate is around 88% left untreated. So we'll move to the pathophysiology. Patients should have a genetic susceptibility, especially among children, or the acquired susceptibility among adults. So this susceptibility should be met with a potential trigger. And this amalgamation, this susceptibility and the trigger will lead to a variety of cellular and molecular mechanisms. The mainly involved cells are the macrophages and the NK cells. These aberrantly activated macrophages secrete various amount of cytokines and several molecules. And serum ferritin is one of the macrophages is considered as one of the very rich source of ferritin. So you will have hyperferritinemia. On top of that, they will produce various cytokines like interleukin-1 beta, interleukin-6, anti-necrosis factor alpha. And then these macrophages and the monocytes will keep on stimulating the cytotoxic T cells. These cytotoxic T cells, when stimulated, they will also secrete a variety of cytokines like interferon gammas and interleukin-2 receptors, which will go and cause multiple organ damage. So these cytokines are the molecules are the responsible cause for the clinical manifestations like fever, rash, vasculopathy, organ damage, and etc. So we'll move on to the possible causes of HLH. As I'm really dealing with the adult population, I'm discussing about the secondary form. Infections are considered to be the most common reason, most often viruses, or it can be either intracellular pathogens. Viruses like Epstein-Barr virus, cytomegalovirus, HSV, and recently identified COVID-19 and dengue, and etc. Bacterial infections like Bartonella, Brucella, and the TB. Fungal infections, histoplasma, and PJP parasites all can cause an HLH type of a picture when a patient have that potential. HLH can be associated with a malignancy that is mostly seen in elderly population, and 90% of the cases are hematological malignancy, especially the NK cell or the T cell leukemia. And solid tumors like teratomas or the breast cancers account for 3% of the cases. And it is associated with rheumatological conditions also. Here, the nomenclature would be a little bit different. We are usually describing haemophagocytic lymphohistiocytosis. The pathophysiology is more or less similar. But if you have a rheumatological condition as a precipitating factor, we'll give it as another name that is called macrophage activating syndrome. So this is considered as a subset of HLH rather than a different disease entity. So we have to look for underlying SLE features, juvenile idiopathic arthritis or adult onset stale disease, and etc. HLH can occur in the setting of immune compromised status as well, like in HIV and post-transplant recipients. So HLH has several clinical phenotypes. That's why I'm specifying more on the physician's role, because we are the people who are getting the first medical contact of a person coming with a variety of presentation. So we should have a high index of suspicion. Most of the cases, 95% of the cases, they will have acute or subacute febrile illness. Sometimes they will initially come to us with a shock, with multi-organ failure, mainly involving the heart in the form of myocarditis, OARDS and AKI. And there is organomegaly, 70% of the cases splenomegaly and hepatomegaly also. Sometimes they can have the lymph nodes. I am emphasizing, if you have lymphadenopathy in the patients who are suspected to have HLH, rather than embarking to HLH, we need to actively go and find out whether we are dealing with a hematological malignancy like a leukemia or else other lymphoproliferative disorders like plasmas. Central nervous system also can be affected in 25 to 50% of cases. They can present with seizures, mental status changes, ataxia, and they are having a risk of developing posterior reversible encephalopathy syndrome. Skin manifestations like erythroderma and the edema and the rashes are quite bit rare in the adult population, but more common in the pediatric groups. So this is how we evaluate these patients. Evaluation of HLH patients need a multidisciplinary team approach. Most of these patients are acutely ill with multi-organ involvement. So the priority of this evaluation is to go ahead with assessment of the extent of the organ involvement, especially the bone marrow, liver, neurology, and the immune activation. The goal is to start the treatment as rapidly as possible. I said the pathophysiology behind this is inaberrant and the aberrant immune hyperactivity, which is causing a very bad cytokine storm. So we need to prevent it then and there if we are suspecting HLH. So we need to find out the active surveillance for the triggering factors like infections, rheumatological disorders, and malignancy, because sometimes the treatment of this triggering factor would be enough. Physical examination should focus on the rashes, bleeding, lymphadenopathy, and the hepatosplenomegaly. So we move on to the lab work. Complete full blood count will say there will be multilineage cytopenias. It can affect both WBC, hemoglobin, and the platelets. And the liver function test invariably shows some sort of hepatitis. It can be either mild form or a severe form. And there is elevated bilirubin. And at the same time, they can have hypertriglyceridemia. But this is one of the feature which shows the liver extended liver involvement. That is most commonly seen when you are having in the late phase life. That is due to the decreased lipoprotein lipase activity. And there will be some coagulation abnormalities. Activated macrophages, they can trigger fibrinolysis. And it is said in the literature that this HLH, in HLH, these activated macrophages can form a sort of pneumologic form of BIC. So that will lead to the low fibrinogenesis with elevated D dimers and the prolonged prothrombin time and the FETT. The inflammatory markers, serum ferritin play a major role here. So I will a little bit more elaborate on ferritin here. Invariably elevated, and it is more than 500 nanograms per milliliter. But it is said in the guidelines and everything, this 500 was extracted from the pediatric population. But when we go through the case series and scenario studies, in the adult population, actually the serum ferritin is quite high. The reported ranges are usually between 7,000 to 10,000. And if it is said that if you have a serum ferritin level of more than 10,000, it has a 96% specificity and 90% sensitivity for HLH. Because these macrophages are the main cell type behind this disease, and the macrophages act as one of the major storage area for ferritin. And it is acute phase protein as well. Soluble interleukin 2 receptors, they are markedly elevated. We are having we can't actually go ahead with these immune markers in Sri Lanka. C-reactive proteins and calcitonin are also elevated. And erythrocyte sedimentation rate, ESR, is elevated, but later on it will fall once the fibrinogen levels go down. CSF is not indicated every time. CSF is indicated if patients has CNS involvement and if you are suspecting CNS HLH. We have to go ahead with the CSF analysis, and if it shows the elevated proteins with lymphocytic pyocytosis and hemophagocytes, that is a little bit rare. So the bone marrow evaluation is very important here. All patients should have a marrow aspirate and a biopsy. One thing is to detect hemophagocytosis, because bone marrow is one reticuloendothelious organ. And apart from that, the advantage of going ahead with the bone marrow is, while assessing for the hemophagocytosis, you can assess for the other differentials. You can look for what are the other causes for cytopenia, and you can look for the evidence of malignancies infiltrating the marrow causing the cytopenia as well. And this bone marrow should be cultured and they should be examined for the infectious organisms as well. This hemophagocytosis on bone marrow is reported in 25 to 100% of the cases. And I would say this hemophagocytosis alone is not enough to make the diagnosis of HLH, but we have to go ahead with the clinical judgment. Hemophagocytosis in the bone marrow will give us a supportive evidence. Sometimes the initial bone marrow might not show this hemophagocytosis. In that case, if we are highly suspecting hemophagocytosis, it is advised to go ahead with the serial assessment. But I am a little bit suspicious it is, to how up to how extent we can go ahead with this, because patients are quite ill with multi-organ involvement. So this way shows bone marrow, and here you can identify the histiocyte engulfing the neutrophil. Diagnosis of HLH in adults. This is basically based on the HLH 2004 diagnostic criteria, that is in conjunction with the clinical judgment and the patient's history. And we need to fulfill 5 out of 8 diagnostic criteria. But this had several caveats. One thing is, this HLH 2004 diagnostic criteria was mainly extracted from the pediatric literature, and it was developed for the research purposes. And this was not criteria for the adult population, as we don't have well-formed research evidence still going on. And this has been quite modified in 2009, and this seems to be more practical. And it is advised, if we are strongly suspecting HLH, you do not have to wait until you get the 5 out of 8 diagnostic criteria. We can just start on the HLH-directed therapy. So here you can see the 2004 diagnostic criteria. You have to fill either A or B. A is quite out here in Sri Lanka. The molecular diagnosis is not feasible here. And in B, you have to meet 5 of the 8 criteria: fever, splenomegaly, and cytopenias affecting 2 or more cell lines. Hemoglobin should be less than 9, platelet less than 100, and the neutrophils less than 1000, absolute neutrophil count. And the hypertriglyceridemia of more than 265, and the fibrinogen levels less than or equal to 1.5. And the hemophagocytosis in the bone marrow or spleen or the lymph nodes, ferritin, which is greater than 500, soluble interleukin-2 receptors, and the low absent NK cell activity. So this is the modified version in 2009, which is more practical. This shows 4 clinical criteria: fever, spleen, cytopenia, and hepatitis, and 4 immune markers: hemophagocytosis, increased ferritin, increased soluble interleukin-2 receptors, absent or very decreased NK functions, and the other results supportive of HLH diagnosis: hypertriglyceridemia, hypofibrogenemia, and the hyponatremia. So if you are in a dilemma, there are website developed calculators, especially in the MedCalc-like sites you can quickly refer. That is called HLH H-score calculator. So that will shows the they will assess the likelihood of being this patient managing as a HLH. So after the diagnosis of HLH, we have to go back and look for the etiology. One thing is the infections and HIV serology and the malignancy, especially in elderly. You can do CT. It can be enhanced by the PET and biopsy of suspicious lesions, and you need to evaluate for the rheumatological disorders. So back to the scenario. So we had 2 differentials in our hands ultimately. So we went ahead with the serum ferritin. It was alarmingly high. It was 25,964. So with that, we thought possibility of HLH in this patient, and we liaised with the hematology team, and they went ahead with the bone marrow. Apart from that, we had a serum triglyceride of 275, which was marginally high, and fibrinogen level was normal, including the patient's coagulation profile. This was the patient's actual bone marrow, histomorphological appearance showing the hemophagocytosis. So this is how we confirmed the diagnosis. We had fever, he had splenomegaly, and cytopenia we kept a little bit aside because he had only thrombocytopenia. And we jumped to hypertriglyceridemia, which was positive, 2,275. And there was hemophagocytosis in the bone marrow, and ferritin, 25,000. So we came to the diagnosis of HLH in this patient. So we actually actively went for the hunting of the etiology. We screened for the infections, UFR, urine, blood, sputum, everything was negative. But patient's CRP was high. We liaised with the microbiology team at this point and started the patient on broad spectrum antibiotics. Chest X-ray didn't show any kind of abnormality. We had a dilemma whether this patient actually had dengue. We did the dengue PCR, IgM, IgG, everything was negative. And EBV, IgM was negative. EBV, IgG was positive. It was suggestive of a quite past infection. COVID was negative. Rickettsia antibodies, EMB, tuberculosis, everything was negative. We look for the malignancies and the rheumatological workup that is again also negative. So we had a little bit deficit here. We could not find out the potential underlying etiology. So these are the mimics of HLH you have to think of. We have to think of either infections or sepsis, liver disease or liver failure, multi-organ dysfunction, catastrophic antiphospholipid syndrome, and the Rett syndrome, drug reaction with eosinophilia and systemic symptoms. So treatment of HLH, this is greatest barrier to successful treatment is the delay in diagnosis because it has difference in severity and the complexity and the rarity is different. That's why physician has to pick this up very quickly and we to liaise with the other potential teams to get down the successful outcome. Therapy is chosen according to the patient's clinical status, and this treatment is a little bit complex and there's no one-size-fits protocol for each and every patient. The basics of this treatment is to target the underlying disorder and control the immune dysregulation. Etoposide, which is a chemotherapeutic agent, it has an action against the cytotoxic T cells, which is available in Cancer Institute Maharagama, and dexamethasone are considered as a mainstay of therapy. So if you are having a patient who are actively ill or clinically deteriorating, we need to immediately start the treatment with HLH specific therapy. Therapy is based on the HLH 94 protocol. We can go ahead with the 8 weeks of induction therapy, and then later on we can assess the patient after 8 weeks and switch on to either this weaning of therapy or to something else, and like cyclosporine, and then sometimes in refractory cases we might have to go ahead with the stem cell transplantation too. If you have CNS disease, we can consider intrathecal therapy with methotrexate, but this is again going to be a collective team work. For clinically stable patients with associated triggering factor, they may respond to triggering condition alone. And we need to find out the underlying etiology actively. Resolution of the HLH without HLH specific treatment has been observed, particularly in infection-associated HLH. And the more conservative approach can be considered with a short course of steroids and in patients who are having less severe disease and improving clinical manifestations. So treatment according to etiology, I will quickly move. Infections need rapid diagnosis and the empiric antimicrobials. If you have active EBV infection with more than 10,000 viral copies, we can go ahead with rituximab or IVIG. For macrophage activation syndrome, the course of pulse corticosteroids plus the treatment of the underlying condition. And malignancy-associated HLH has the worst prognosis of all HLH subtypes. And we need to balance the HLH-specific therapy and the tumor-specific treatment. And again, corticosteroids are used under the line. In highly active conditions, we can use etoposide prior to tumor-specific treatment to buy some time. So our experience, So this patient's fever was continuing, and after the bone marrow, we showed the haemophagocytosis and fulfilled all HLH 5 out of 8 criteria. Here, we started the patient on IV steroids, and you can see the nice fever reversals. And then a more conservative approach, we discussed with the hematology team and the microbiology team, and then we approached the conservative management because patient was showing clinical improvement, and he was biochemically and hematologically improving. Patient was switched to oral steroids and tailed off over 8 weeks. Upon discharge, after 10 days of hospital admission, patient's ferritin was less than 4,000, and the platelet count was more than 200, and the liver transcendents were less than 300. So this was a success story from CNGH. Actually, the take-home message is HLH is considered as a potentially life-threatening syndrome due to excess immune activation. And physicians has a major role because it has a multifaceted aspect. They will come with fever, organomegaly, and cytopenia. If you have this trilogy in your patients, we need to think of underlying HLH and include this in your differential diagnosis. And demonstration of haemophagocytosis in reticular endothelial system would not alone be enough. We need to go ahead with the clinical judgment and need meticulous search for the triggering factors. And this is going to be anyway multidisciplinary team effort. We can't alone manage this one as everything is complex. So these are my references. And this blue ribbon depicts for these histiocytic disorders awareness. And the histiocyte organization worldwide has taken month of September as the histiocyte awareness month. And this is the end of the presentation. And I would like to thank my consultant, Dr. Yamuna Senadir, and Dr. Yasinta Costa, consultant hematologist, for guiding me. And my pre-MD trainers, Dr. Ananda Janagi and Dr. Harendra Kannatilaka. And I would like to thank Ceylon College of Physicians for giving this prestigious opportunity to address this professional body. And thank you very much for your kind listening.
Thank you, Dr. Amar Singh. That was a very useful presentation and the clarity of the slides and the way you spoke. Small question. Hey, you said one of the presentations is neurological.
Yes.
How do they come up? Say now, now when a person comes with a neurological looking illness with loss of culture, how do we set about? How do we find whether these are HLH associated thing? Because my thing would be there is a meningitis encephalitis.
Yes. This is also going to be we have to go ahead with the history and the examination. If you have a potential trigger identified quietly in the history, like a potential some sort of previously preceding acute febrile illness, maybe sometimes patient has underlying rheumatological condition, and then we have to do the active search. You have to specifically look for the supportive evidences to come to a diagnosis of HLH. You have to specifically look for the spleen. And in the investigations wise, if you have unremitting fevers with cold resolving cytopenias, then at that point you have to pick up this could be a HLH-like. So presentation of CNS alone is not enough, sir. You have to see whether this patient has spleen and ongoing unremitting fevers and whether the patient has cytopenias. In that case, we can raise the question to the hematology team and ask to go ahead with the bone marrow and look for haemophagocytosis. The bone marrow is not only the essential thing. We can go ahead with the either lymph node biopsy if it is available in the outside, sir. So that is again going to be, it's not a single thing. It's going to be the clinical judgment depending on the history, examination, and the investigation, sir.
Thank you.